Okay, good afternoon for all the audience who stay connected for the second lecture of Dr. Mark Richardson at the 2021 IWBNC. He's going to share his lecture titled Evolution of DBS, Closed Loop and Connectomics. Please write your questions in the Q&A panel. We will read them at the end of Dr. Richardson's intervention. Please continue, Dr. Richardson, and thank you. The microphone is all yours.
Well, thank you. Okay, so thanks everyone for sticking around, and welcome to anyone new who may have joined. We'll switch from epilepsy to DBS for movement disorders and psychiatric disease. Yeah, please do send your questions in. There'll be plenty of time at the end to go over those. So, although we're switching diseases, you'll see a kind of similar theme, actually, of understanding the network physiology and why that's important. And so let's just jump right into this question. Not whether we should have closed loop DBS, but why should DBS be closed loop? And there are a few reasons. Even though DBS works pretty well, on average, it doesn't work perfectly in any patient. And in some patients, it doesn't work as well as we expect it to. And that can be because of side effects that aren't explained necessarily by a bad lead location. It can be something specific to the patient's disease, particular symptom that is more intractable for them. Simple things like reducing battery life with the amount of current that is delivered. And Simon Little, who's been a pioneer in closed loop DBS, published a paper a few years ago about less speech symptoms with closed loop DBS. Wasn't clear exactly why that might be the case. It might just be less stimulation all the time. And we don't understand how the basal ganglia exactly process speech, but being able to record the correlates of different behaviors from different brain regions could be very important for how we deliver therapy and DBS and how we can tailor that for individual patients. So I guess a short answer to this question would be, in order to personalize DBS for a specific patient's physiology or symptoms. All right, so we'll talk about the extent to which that's possible. We'll just skip to slide. Okay, so this is a schematic that shows my interpretation of the potential evolution of closed loop DBS. And so this is the stage where we are now, which is sensing-enabled DBS. So with the advent of the Medtronic Percept system, one can get some brain recordings. The actual closed loop features are still locked, so this is just sensing-enabled, so everything's manual. In adaptive DBS, DBS system adjusts its stimulation on its own in relation to a trigger. This would kind of be like the RNS, how the RNS works for epilepsy. There's a trigger, the device is either on or off. You can imagine different variations of adaptive DBS in terms of what the signal is exactly and how it's modulated when it comes and goes. And this type of system, of course, still requires attention and kind of manual adjustment of medication. You can also envision, this is where we would really like to be, intelligent adaptive DBS or AI DBS, where the onboard system is learning about the brain physiology. It can differentiate different behavioral states. It can assess changes in physiology over time. It might as an input function, have medication dosage. And maybe it could recommend its own settings or even medication adjustments or timing. And Julia Newman wrote a nice review paper on this in Neurotherapeutics a couple of years ago. I do think that this evolution has a potential to be informed by learning from implanting DBS in different diseases, not just movement disorders, and can also learn from our experiences in epilepsy and across devices. So this is one reason why functional neurosurgery is so exciting, is this ability to think about how the brain works and how we can modulate its activity as we understand the pathophysiology. So let's review the current state of the art. So now this, it's been several months now since this device was approved in Europe. So this is the sensing-enabled device from Medtronic. This evolved from the PC plus S. The plus S stands for sensing. And now this has been available in the US for now for several months, maybe a year now in Europe. Time flies in the pandemic. So we can stream some activity while the patient's in clinic. There's very limited ability to record from the device when the patient's out and about, at least with the current features that are unlocked. Having said that, this device is moving towards use as a closed loop adaptive system. There is now a clinical trial that's open and enrolling. We're participating in this at MGH. Dr. Harrington and our group has recruited a couple patients into the screening process. And so I thought I would just share a couple things about that. So this is a historic clinical trial. To be clear, it's the first full clinical trial of adaptive DBS. And let me just say, there have been several reports of how to do and how to think about adaptive DBS in the setting of externalized DBS leads. And I'll specifically review some of the very recent publications on using implanted devices, the initial attempts of, with implanted devices to do closed loop DBS that are outside of this trial, really go beyond this trial. But this is a current state of clinical trials. So it's a prospective single blind randomized crossover design. It's multi-center. I think 6 sites in the US and 6 in Europe, roughly. 36 patients, total evaluation period 15 months. The primary endpoint is a comparison of standard continuous DBS, duty cycle, to adaptive DBS by counting hours of on time without troublesome dyskinesia, as reported by patient diary. So subjects are going to receive the standard continuous DBS at baseline to just establish the expected clinical efficacy. Then they'll be randomized and there'll be a blinded evaluation in comparison of 2 different adaptive algorithms. So I'm just going to show you a plot from each of the kind of seminal works. And this is work from the Oxford group that illustrates the single threshold mode. And the trigger here in Parkinson's disease, the initial trigger has been beta activity, which in not all patients, but in many patients with Parkinson's disease is elevated and corresponds most often to the symptom of bradykinesia. So there's a pathologic elevation of beta oscillatory activity in the basal ganglia. So the idea here, so here's the LFP signal. Here it's filtered to see the beta burst. This straight line here would be the threshold of beta power or amplitude. And this squiggly line is showing you the average, essentially, amplitude of beta power. And you can see when it crosses the line, you go up, trigger is turned on. That's this square wave here. And then here's a schematic of the stimulation. It ramps up, it's on. Simulation is on. We know that it can drive the beta power down. That's the correlate of symptom improvement. And you see the beta power dip here. Simulation goes off. Trigger is kind of reset. And here the beta power increases, and you can see this continues. So this is a single threshold mode. There's just one line. Cross it in one direction, the simulation goes on. Cross it in the other direction, it goes off. The work of Helen Bronte-Stewart at Stanford has taken a little bit different approach, where this is a dual threshold mode. And there, the idea is that there is a kind of normal range of beta activity. Let's get that back. And if beta activity increases over this range, DBS is turned on, and if it decreases, it's turned off. And the idea here is to try not to undertreat and try not to overtreat. And you can see an example here on the right, which is showing a beta power going down as DBS voltage goes up, and limb, this is accelerometer data, is increasing, essentially patients moving better. Okay, so those are the two modes that will be tested in this clinical trials. This is very exciting. And hopefully will lead to FDA and CE approval of the technology that already exists on the device, and it can be unlocked. And that'll be really another just huge milestone in the field of DBS. Okay, so there are also ongoing what we call investigator-initiated studies, where people in the United States through the Brain Initiative and other mechanisms are using devices on their own to start figuring out closed-loop DBS. Okay, so here I've chosen 3 examples from the recent literature to review that those who are interested in this field should really be aware of. So the first that we'll talk about is from the Oxford group, Peter Brown's group. And this is, this strategy in this report was developed for essential tremor with the signal being derived from the DBS electrode itself and the BIM nucleus. So one thing to note is that this processing is not done on the device. Leads are externalized. There's a computer where the algorithms are run. It's connected to simulation. And so this is done in the setting of having leads externalized before stage 2 DBS, which gives a great opportunity to test these paradigms. So what this group did was to develop actually 2 algorithms. So people with essential tremor some people will have a tremor really every time they go to initiate a movement. So you can basically make an assumption if they're going to move, that their tremor is going to come. And so that's what the top plot is showing, where the algorithm decodes when this movement is happening. And it does that through assessing the spectral activity. But there can be another type of tremor, which comes from, which can be postural tremor. So the patient is in a certain position, they're not moving, they're holding that position, or maybe they're doing some fine motor something, and the tremor is very active in that particular position. So they develop a different algorithm to detect that, and you can see that here. Here's the EMG, and here's the signal essentially. Here's an average of the tremor power, and here's the signal turning off and on. Okay, here's a different approach for a few reasons. So also an essential tremor, but this is University of Florida group, where they have ECOG strip electrodes implanted over motor cortex, and in particular over hand motor cortex. The idea here is to, again, an external device is used to do training of the algorithms that will determine the detection parameters. And the patient comes in after being implanted and goes through different training periods and specific tasks. And And here's an example of just a schematic of what that looks like. And here's streamed data from motor cortex, contralateral movement. You can see beta desynchronization. Here's ipsilateral hand movement. What else can I show here? And these are they reported on 3 patients. And this is a further illustration of what the data looks like. Now we're hearing data, now we're seeing data from the thalamus itself. Contralateral hand movement. Here you see the beta desynchronization. You can see in the thalamus it's not as strong. And here again, you can see it kind of zoomed in, movement onset. Detected in the thalamus, but obviously much stronger in the cortex. And this is an estimate of when stimulation will be applied. So they train their algorithms and then they can implement this. This is an example of what this looks like. Take-home message here is that it makes a lot more sense for this type of approach where you want to stimulate whenever the patient's going to move by recording from the cortex. And that symbol is very robust and avoids problems of stimulation artifact in the DBS lead, avoids problems of where you have to set the bipolar recording pairs, for instance, which can affect where you might stimulate. And DBS for essential tremor can work extremely well when you're stimulating in the right spot. And if you have to move that spot too much, then the efficacy is not as great. So the idea of decoding the intent to move from the cortex and then stimulating the thalamus makes a lot of sense. And in fact, they showed very nice results in this initial paper. And that, of course, was with the implanted device and cortical leads. So you can see the Oxford group also reported in their kind of acute study tremor reduction that was consistent with regular standard DBS. And there was an energy savings, importantly, because just less current is being delivered. So this has advantages for not having to have the battery change as much, which is very attractive to patients. And even if there was a rechargeable, let's say, not having to recharge it as much. So DBS is supposed to be a quality of life improving surgery. So anytime we can do something like that, that essentially lowers the burden on the patient and these chronic diseases where they're going to have a brain device implanted, I think is extremely useful. And the University of Florida group showed a similar result. Good tremor control consistent with what we expect from standard DBS, but with the cost savings on the energy side. Okay, and here's a really exciting result that is recent from the UCSF group, where these are patients implanted with a version of the device that can stream information wirelessly to a tablet. And these patients even had data kind of coordinated from an accelerometer on a watch that can give a readout of tremor, bradykinesia. And the group was able to train algorithms that use this information that was collected in patients' homes to adjust the settings on the device. And this is just an example, and again, using cortical and subcortical recordings. So here, these are, I think, this is one patient example. 3 canonical frequency bands that are generally associated with tremor in the alpha band, beta with bradykinesia, and dyskinesia with gamma oscillatory or activity. And actually, these are 5 subjects, because the point of this is the heterogeneity between subjects. I think this is subjects, now I've confused myself. Or contact locations, things, subjects. Because you can see that the activity, for instance, recorded in the STN. So here's strong beta activity, this particular patient. Is not necessarily present in the other patients. And so here you can really get a sense of the need for personalization in a closed loop system. DBS isn't a one-size-fits-all approach, and even closed loop DBS isn't a one-size-fits-all approach. It's important to really be thoughtful about this. And so they were able to develop a control signal from beta, from subthalamic beta activity, as well as a different control signal potentially related to dyskinesia from cortical gamma activity. And here you can see adaptive DBS working better than open loop. So very promising and really very exciting to have data collected in a patient's home that's used to inform the closed loop system. We're really starting to see some very exciting advances in this field. Okay, so let's see. Why did I put this slide back? Aha, because, okay. What about getting to this stage where the device is, in the example we showed, the device is not doing all that work itself in terms of incorporating the data collected at home. So how do we get to a stage where that's possible? One is the application of machine learning techniques, which currently have to be done offline. There isn't the onboarding processing ability to do these really kind of high level decoding problems on the device. Here's an example from a review paper that was written by Timon, American, Victoria Peterson, Julian Newman, with a schematic that shows the type of processing features that we would like to have on the device at some point. For the time being, this work has to be done separately. And our own approach to this has been to use the operating room to record this data, because we don't have patients implanted with the PC plus S or the RC plus S device, but we do intraoperative experiments with cortical strip electrodes. So this is now an old data set, but one that we've continued to look at, now apply machine learning techniques to in terms of decoding movement. And we wanted to ask the simple question of whether we could decode this more easily in the cortex and the STN, and whether it was helpful to have the STN recordings. In this initial data set and approach, the answer was it's easier to decode from the cortex, and the STN is not particularly helpful. This is a schematic that just shows you the steps involved in setting up a decoding pipeline to answer that one question that we ask here. It's very simple, which is, when's movement onset occurring? So this is a lot of work, but these are important steps for thinking about how this evolves in the future. And as kind of a transition to the next part of the talk, I'll show you this, which was a correlation that Timon and Julian did to determine whether there was anything predictive in functional or anatomic connectivity that would help to predict which locations gave the best decoding performance in terms of movement onset. And not surprisingly, when looking at fiber tracking, at tractography from a kind of global connectomic database, leads that were in primary, or contacts that were in primary motor cortex, gave the best coding performance. So this is kind of validation that this technique is giving us the expected answer. Interestingly, when you look at the fMRI-derived functional connectomics, you see the expected hotspots for electrodes that gave the best decoding ability as predicted by the functional connectivity, but also areas in the cerebellum showing up. So this is very interesting because it's a technique, a way of thinking about the data that may help us understand the brain networks involved. And this is essentially preliminary in the sense that this is a few patients we haven't specified the connectivity related to specific symptoms, etc. But we do think this is a very interesting approach to thinking about, for instance, where's the best place to put a cortical sensor? And that may be obvious with this question, where's the best place to decode hand movement? It may be less obvious for something like a speech symptom, and may need even more help for cognitive side effects of DBS. If, for instance, we move into an era of also doing DBS for non-motor symptoms of Parkinson's disease in conjunction with treating the motor symptoms. On that note, speaking of non-motor symptomatology, I'll show you these two examples of an approach which is very similar in two separate groups to use stereo EEG to guide DBS. And now we're talking about for major depressive disorder. So on the left is a schematic of the approach from the group at Baylor and UCLA to implant regions of interest that are implicated in network dysfunction and depression with DBS leads in presumed target of interest, but also recording from other areas that would be expected to provide useful information for how to do DBS programming. And this approach uses the segmented lead in the Boston Scientific System. And then the group at UCSF has taken a very similar approach in terms of the hypothesized areas for implantation to map depression network and responses to stimulation. And these patients after SEEG subsequently implanted with RNS. So I think the outcomes of these trials alone are going to be very interesting, as will be the outcomes related to different device and approaches used. So I think this is very, very exciting, and we're just now starting to see the first reports of any of these patients. It's very difficult to do this work. And so I think both these groups are really to be commended for advancing the field in terms of how we think about treating these disorders. And I thought it was important to note that that approach didn't start there. I think this is kind of often overlooked strategy that's been published for pediatric dystonia by Dr. Sanger, I think primarily leading this. And this is very interesting, where multiple targets in the basal ganglia and thalamus are implanted with SEEG leads, including Benke-Fried electrodes with extended microwires, where single unit activity is recorded. And looking at the spike data in response to simulation is actually part of the algorithm for figuring out whether or not to implant the patient. You can see that here on the schematic. So I think we're going to see this approach more often for different diseases. And I think what we've learned from doing stereo EEG and epilepsy, and if you were in the last lecture, I'm sorry, with the technical snafu there, I think I lost some slides on stereo EEG that weren't saved because we didn't spend a lot of time talking about the stereo EEG data itself and how to use the semiology to understand the network. But what we have learned from using this so much in epilepsy is that it's safe. And for these diseases, major depressive disorder and others for which patients have just failed over and over again medical treatment, I think it's perfectly reasonable to invasively assess the network to figure out the best place to potentially perform neuromodulation. Okay. Let's shift into this area, which is frankly a new area for me, but been very motivated by the fact that Andy Horn, the creator of Lead DBS, is moving to Boston. He's going to work with Mike Fox at the Brigham and also have a presence at MGH, working with some of our neurosurgical data. And Andy and Mike published this very nice review paper in Neuroimage, and I've taken a few of their figures to show the potential of this type of approach. So one thing to just recognize is that through patient-specific imaging, whether it's functional or structural, and so when we think of connectomics, we can think of those essentially two modalities: tractography and functional MRI, typically resting state, to derive a connectivity map in an individual person's brain. However, it's really difficult to do that accurately on a single patient, certainly with a single scan. And so normative connectomes are potentially a way around this problem, or at least a different way to think about this as techniques are developed to improve single patient connectomic imaging. Because combining patient data obviously can be more powerful, can bring out these relationships. And so this has been applied now in relation to DBS for Parkinson's disease, essential tremor, OCD, to show that regions that are most often associated with clinical improvement in DBS and these various disorders are associated with specific network topologies. And so, okay, so here's an example of a functional network. And this is something similar with the structural network. And at the top is OCD, showing fibers engaged in patients who respond that are red, and the fibers predominantly engaged in patients who don't respond in blue. And the bottom is Parkinson's disease, showing that the activation of these premotor fibers being important in patients who responded. And so I think the take-home message here is we're starting to define connectivity targets that we might like to engage when we do DBS. And maybe we'd like to have confirmation that we're doing that. Or not. Maybe we don't need to. Maybe we can map this out with imaging before surgery and just put the electrode in the right spot and make the assumption the network's going to be activated. And I think that's a very interesting question for future work. And then I just pulled, there were 8 kind of lessons about opportunities from this review paper, which I'll show here. Explaining and predicting clinical improvement is a good one. I think the flip side of that's also very important. Explaining clinical failures, linking different DBS targets to the same network. Example, depression in OCD potentially. Defining networks for specific symptoms, doing more to improve patient-specific connectomes. Of course, mapping side effect networks. And this is what I just mentioned, guiding the surgery itself. And of course, programming. Potentially using multimodal therapy, so non-invasive brain stimulation to target one aspect of the network. And of course, this one, critically important, there's the potential to understand things about functional and structural connectivity that explain aspects of disease or treatment that weren't recognized without doing that. So, one question is, if we can do all of this fancy imaging and determine where the networks are that need to be modulated, and we can do DBS asleep and an MRI, and we can do that all at the same time, why do we need to do awake DBS surgery? So I think this is an open question. I'd say short answer is patient specific variability in physiology is one reason. We don't know who's going to have a good beta signal or who's not unless we record. And someone who has that present in the operating room isn't always going to have that to the same extent outside of the operating room. And then there's the ability to understand different symptoms and different behaviors, and placing cortical sensors in regions that are important for specific patient symptom control or side effect avoidance. And in my group, we've been looking at the role of basal ganglia and thalamus in speech production. And so this is an example of an intraoperative setup to do that, where we put a strip electrode over speech motor and auditory cortex, while we have electrodes recording single units and local field potentials in the subcortical target as the patient is producing speech. And this just, the middle image just shows you the microelectrode holder, microdrive on the robotic arm, and you can see the wires coming out of the burr hole here from the temporarily placed ECOG strip electrode. But you could imagine if a patient has a particular problem with speech, bradykinetic speech, stuttering speech, as a primary component of their Parkinson's disease, that we might place a cortical sensor in a speech-related area, in addition to a sensor that maybe is in their hand motor area to help with their hand tremor, their bradykinesia there. So I think there's a lot of potential here, and Awake DBS Surgery, I think, is alive and well to help answer these questions about the relationship of the structural and functional imaging to the actual physiology that we can record during awake behavior. And those questions can't all be answered with the implanted devices because, at least for the time being, the areas in which they can assess are greatly limited compared to what we can do in the setting of awake DBS surgery, even though there our main constraint, of course, is time and patient fatigue and participation. Okay, and that's all I have there. I'm happy to take any questions, discuss anything in the presentation, or anything I didn't discuss.
Great. Thank you very much, Dr. Richardson. It was an excellent lecture. Very complete, and give us the current vision of DBS, ADBS, and intelligent ADBS. Excellent. It was really nice. Yes, we have some questions right here. Ali Bayramov is asking, how effective is deep brain stimulation for refractory obsessive compulsive disorder? How does it work, and in which mechanism?
These are all great questions. The one randomized controlled trial that attempted to show that this was efficacious was not able to do that. But in our experience, and certainly experience at MGH, where there have been a lot of patients implanted in the nucleus accumbens ventral striatum, that the efficacy on average is quite good. And so when we do this, we really expect it to work when we have the proper patient selected. The target is really the anterior limb of the internal capsule. At least that's what seems to be clear from Connectomic work and just the evolution of the targeting. How it works is not clear. We had one patient recently, this is anecdotally, who is almost a complete responder to DBS. Why that is and exactly what circuits are being modulated is not clear. And I think one of the reasons for that is the number of patients, the criteria for implanting someone with OCD, with DBS is very high. The Y-box score that's required is high. So these are people with very severe OCD. Many of these patients, it is extremely difficult for them to manage to get into the hospital or to finish the required other treatment attempts that they need to do. So one problem that the field suffers from is not that many cases of OCD DBS being completed. So that doesn't answer the question. Short answer is I don't know why it works beyond the basic stuff that that's been reported about network modulation, and but I have seen it work quite dramatically. So it's clear there's something there.
Yes, right. We have another question. In your practice, Dr. Richardson, have you considered DBS and Connectomics for treatment in eating disorders, such as obesity?
In my own practice, I haven't done this. I think there are two examples of well, at least in the U.S. In China, there have been some studies related to this. I'm not familiar with those, and in Europe, I'm sure there's some trials I'm not familiar with. In the United States, Don Whiting at Allegheny General has published a couple times in his case series of hypothalamic stimulation. My understanding has been hard to get a persistent response for overeating, eating disorder. I did see promising data presented by Casey Halpern at Stanford related to using the RNS system to detect a, let's call it overexuberant reward signal related to binge eating, and potentially to modulate that with RNS in the nucleus accumbens. And that was very preliminary data, but seemed promising. And that's the state of the art that I'm aware of related to at least overeating disorder.
Okay, and there's another question quite similar in its pathophysiology, and it's about DBS in order to treat drug-related addictions. What's the role that if there's any
drug
role,
addiction?
Yes, if there's any role of DBS in drug addictions.
Yes. So over the years, there have been various studies, and I don't honestly know what we can presume that that there hasn't been a blockbuster there, because if I looked this up several years ago and kind of did a survey of the literature. So one thing that's really hard about addiction is you have to, I guess you don't have to, but one typically picks the type of addiction: alcohol addiction, or it's opiate addiction, some other drug-specific addiction. And these patient populations can be very difficult to work with. I'm actually surprised that, and maybe there is a trial or some a project ongoing that I'm not aware of, but I do think that we're going to see this. I think this is an obvious place for DBS to go. So I think there's definitely potential there for drug addiction as we understand these circuits better, and for instance, OCD and movement disorders. I mean, the basic answer to the question before about OCD is, I think we can make an assumption that the effect is similar to what we see in movement disorders. It's just that we don't know exactly what the signal is, the pathologic signal that's being interrupted in OCD. But there's some sort of pathological probably synchrony between brain regions that doesn't let normal behavior proceed, and that is somehow blocked by DBS.
Okay, great, thank you. Dr. Madriñan asks, do you perform magnetic resonance guided focus ultrasound? What's the future for this type of therapy in the short term?
Yeah, I don't. So I'm not really qualified to answer that. We don't have a focus ultrasound at MGH yet. My understanding is that that the morbidity associated with this for lesioning the thalamus, for instance, in essential tremor, has improved significantly. And I think initially when focus ultrasound was kind of getting going, at least my read on the literature was that the associated morbidity was too high in relation to DBS. And so I think that's changed now. My personal opinion is that focus ultrasound is not a good option for most patients with Parkinson's disease because they don't have just one symptom. They have more than one, and they have, I think, a greater need for a therapy that can be modulated. As focus ultrasound evolves, could it replace laser ablation, let's say for treating epilepsy? I think that's reasonable, but I don't have direct experience with focus ultrasound.
Okay, and also Dr. Madeleine asks, do you think magnetic resonance guided focus ultrasound may have a role for fenestration for the floor of the third ventricle for obstructive hydrocephalus?
That is interesting. Short answer is I don't know. My understanding is that the physics of focused ultrasound have not advanced to the point where that could be safely done. But honestly, I'm not sure.
Okay, and Dr. Sanchez is asking, what's the future for DBS for depression and Alzheimer's disease? Well, I think you talked some about this in the lecture, but if you can complement anything.
Sure. I think there is still, I'm a strong believer in the potential of DBS to help patients with major depressive disorder. And I think, the work that Helen Mayberg has done at each institution where she's practiced has, I believe the results, that those groups have gotten, and they have a very thoughtful approach to using connectivity prospectively and have a very good sense of patient selection. It is hard to translate that experience in general. It's highly specialized, but I think, frankly, we should see more attempts to recapitulate the basic work that Dr. Mayberg has done. I think these stereo EEG attempts are going to advance our understanding dramatically, and we'll see how long it takes to really have a kind of order of magnitude leap forward, which is what we need there. Alzheimer's disease, I'm less hopeful about. I don't understand the mechanism through which DBS could help patients with Alzheimer's. And I'm a little skeptical in general of that approach, but it could be that I just don't have an adequate understanding.
Okay. Dr. Richardson, in your practice, do you favor an very early DBS surgery for patients with Parkinson's disease? Or what's your opinion about that?
Yeah, everyone's version of early and very early is different. So I would say, in general, yes, I favor early intervention. It's really, again, about quality of life for the patient. But as soon as someone is having a problem with adequate control of motor symptoms with medication, or they're having motor fluctuation, or some side effect or some inability to advance their medication to control their symptoms, and they clearly have Parkinson's disease, then as soon as they're ready, it makes sense to do it. I think there are a lot of benefits to doing it. As soon as the patient's ready, once they cross the threshold into candidacy, then yes, I'm an advocate for that for sure.
Okay, thank you. In your experience, what do you prefer for subthalamic nucleus between intraoperative MRI versus microelectrode recording guidance?
Right. So this is another good question. I am biased for both. And so the short answer is I don't favor one or the other, and I try to leave this up to the patients. And so this is also the way the residents ask this question too, when they rotate onto the service. How do you decide, or how's the patient decide? In our practice, it's pretty easy. I explain what our biases are, and I have a bias to wanting to provide a sleep DBS, at a very high level and maintain a good experience with that, because there are patients who will not have awake DBS. And so it's important that we do a lot of a sleep DBS so that we stay good at it and help to develop that technique, which is very helpful to some patients. On the other hand, I like doing awake surgery. We have NIH-funded research to explore different behaviors related to basal ganglia and cortical activity. And I tell patients that, and patients tend to fall into categories of being very interested in that and kind of interested in the idea of being awake, or they fall into the category that they're definitely not interested and would like to be asleep. And then sometimes you have a middle ground of patients who they see the value of being awake. They get the sense that our neurologist, who's fantastic and will be in the operating room there, that they would get to work with him, and they prefer that. But maybe they don't want to, not so interested in the research, which is fine. So I'd say those are general categories. In Pittsburgh, we published the first 20 STN cases that we did in the Magnet, with those that we did with microelectrode guidance. And like other groups who have done something similar, we couldn't see a difference in outcomes, or side effect profile was one thing we looked at in that paper, or complications. So that was just open label, single center experience, but that experience matched that of others. So I think short answer is efficacy should be the same. It's important to be honest with the patient what your motivations are for either approach, and the patient picks.
Excellent. There's another question. Do you favor STN versus IGP DBS for Parkinson's disease, or what's your preference?
I don't favor one over the other. For instance, I've seen GPI produce a great tremor control result, where typically it's thought that the STN is the better target for that. We do tend to implant GPI in patients who have dystonia as a primary component of their Parkinson's disease, even though the STN is also a dystonia target. We have taken that kind of traditional approach. For patients with dyskinesia, that can be sometimes a more difficult question, depending on what we think the cause of the dyskinesia is. And if it's medication, there's a real need to lower the amount of medication to control the tremor, and we think that would be most helpful. Then we might pick the STN, even if there's a chance for causing some temporary worsening of dyskinesia that has to be worked around. So it does seem that in the STN you can lower medication more easily after DBS. And there's the older population who, if there is any concern on the neuropsychology, we tend to implant the GPI, even though the literature does not necessarily support that there's a difference there. I think it is a larger target, so maybe on average you have less chance of maybe a misplaced lead in a thinner older person's STN, and therefore maybe that's a reason that it's you might have less chance of a cognitive side effect. But for the most part, we don't always favor one or the other. We try to tailor it to the patient.
Yes. The next question is, what are the most frequent complications encountered during DBS surgery?
Well, let me think about that. Well, I think the one that is, how about it this way? The one that I'm most concerned about is not having the electrode in the intended target. And so in our awake cases, we get a CT during that admission, and we compare it to the plan, surgical plan, because there are some cases where someone's made a mistake on, snapping the block on and the lead's moved or something like that. And I prefer to fix those as soon as they're detected, as opposed to discovering it later. Another philosophy is to wait for any brain shift to settle and get a post-op CT a month later. I would just hate to discover a basic problem that far down the line, and we'd like to, have the feedback that we've put the lead in the spot where we expect it. And then for asleep, I do think the MRI, even though a sleep CT guided verification has a really high accuracy. My preference is obviously to do those asleep cases in the MRI. The worst complication, the one that you should really watch out for is, I think, venous infarct. Aside from just being very careful with the planning and avoiding vasculature, one thing to watch out for is a venous infarct, where the case can be done very well, but maybe there was some brain sag and the patient was dehydrated, and there's an unexpected venous infarct that shows up, and patients can recover from that pretty well, but you want to avoid it if at all possible. So you be very careful in opening the dura and ask the anesthesiologist to make sure the patient's hydrated during the case. Is another trick.
Thank you, Dr. Richardson. And the last question for this session is from Dr. Sanchez. During the assessment of choosing the ideal target for DBS positioning in Parkinson's disease, can we consider the local field potentials to be similar network as occurs in the epileptogenic zone in epilepsy?
Yes, so we do. We can do that, and there's certainly publications that support doing that, primarily from Haggai Bergman's work and other publications that have used, for instance, the Haggai component on the neuroomega system, which assesses beta activity, can help with placement. So short answer is yes, I think we should be doing that. Longer answer is we don't fully understand the variability patient to patient and why we, for instance, don't see as much beta in some cases, and what other biomarkers we should be looking for intraoperatively. I don't think we're at the stage of movement disorders where everyone needs to get SEG, to assess this. But I think there are probably some examples of difficult cases of, for instance, patients who would be expected to respond to STN or GPI stimulation, and for reasons that are difficult to understand, just don't. Maybe those are patients that need broader simulation of the network.
Thank you very much, Dr. Richardson. On behalf of CIEN, I would like to thank you again, Dr. Richardson. We are really grateful for your participation and for your time in the 2021 IWBNC.
Dr. Pena, thank you. Thanks to everyone for the invitation. Appreciate it.
Thank you very much. For all the audience, keep in mind this lecture will be available on our website starting from the next week. We hope all the audience to be connected for the next conference, which is Modern School-Based Surgery, 6+1 School-Based Projects by Juan Fernandez Miranda. Please follow the link pinned on the chat screen and check the program schedule on our website, seeingwhois.com. Thank you very much.